Lecture's entitled Functional Anatomy of the Hand. It is really just about flexion and extension of the fingers. It's not entirely about functional anatomy of the hand, but flexion and extension of the fingers is more complicated than you might think. When you talk about flexion and extension of the fingers, there are two groups of muscles involved. There are the extrinsic muscles and the intrinsic muscles. Extrinsic means lying outside the hand. Intrinsic means lying within the hand itself, those that you will dissect today. These are the extrinsic digital flexors. Now, these are flexor digitorum superficialis and flexor pollicus longus, which is a digital flexor, but not a flexor of a finger. It's a flexor of the thumb. Thumb is a digit, but not a finger. And deep to flexor digitorum superficialis is flexor digitorum profundus. And that you know from your dissection on Monday. So these are the extrinsic flexors. This you will not dissect until Friday, but I'm going to need to talk about them anyway. These are the extrinsic digital extensors, the muscles that lie in your forearm but send tendons into the hand so you can extend your fingers. There is a muscle that sends tendons to all four fingers. That's called the extensor digitorum communis. There is a muscle next to it which sends a tendon into the little finger only, and in fact it joins the tendon of the extensor digitorum communis that's going to the little finger, makes it bigger by joining it. That is called the extensor digiti minimi. It's obvious that its name means it extends the little finger. There is a muscle that is deep to the extensor digitorum communis, therefore cannot readily be seen in this drawing. It will be in dissection after you cut through extensor digitorum communis. That muscle which lies deep to extensor digitorum communis sends a tendon that joins the tendon of the extensor digitorum communis to the index finger. And that muscle is called the extensor indicus. So we just see its tendon right here. So those are the three external finger extensors. Extensor digitorum communis to all four, extensor digiti minimi to the little extensor indicus to the index. I'm not going to delve in all of these other muscles which extend the thumb, because today I'm just going to talk about the fingers. But there are muscles designed to extend the thumb. Now, here are some intrinsic muscles, muscles that actually lie in the palm of your hand. That's very interesting, not very interesting. When I was a college student, I had dinner with a friend of the family who was a pathologist. He was a practicing pathologist. And I said, gee, you know, one thing I've always wondered, do you actually have any muscles in your hand? And you know what his answer was? I have no idea. So he had gone through medical school, and by then he had completely forgotten any anatomy related to the hand. There are actual muscles in your hand. If we're looking at the back of the hand, there are these which you see between the different metacarpals, and those are called the dorsal interosseous muscles. The plural is interossei, but each one is a dorsal interosseous muscle. And in fact, you'll have, if you did any reading in advance, realize that although we're not going to be talking about, we're going to only be talking about their role in flexion and extension, they are in fact active in abducting your fingers. The dorsal interossei abduct your fingers, spread them apart. Then if you look at the palm of a hand, there are palmar interosseous muscles. They arise from only one metacarpal, whereas the dorsal arise from adjacent metacarpals. There is also a palmar interosseous for the thumb. I have to say that because one of my colleagues considers himself an expert on the palmar interosseous of the thumb, even though it's a totally useless muscle, and therefore does not appear in most books. The palmar interosseous muscles that always exist squeeze your fingers together. You can read more about that in any book. But we're going to talk about their role in extension and flexion. But they squeeze them together. That's called adduction. And then finally, of the intrinsic muscles that I'm going to be talking about today, because there's others which I'm not mentioning, are some which arise from the tendon of the flexor digitorum profundus and insert into some tendons on the extensor tendons on the back. We'll be going into this in a bit more detail. But you just have to know that there are these muscles arising from tendon to flexor digitorum profundus, inserting onto the backside of your fingers, and those are called lumbricals. And you'll see those as well. And they have a very complicated function. All right, finger in lateral view. You'll notice that I drew that finger partially bent. Why did I draw the finger partially bent? Because unless you go like that, your fingers are partially bent at rest. And the reason your fingers are partially bent is because the flexor tendon of the flexor digitorum profundus, which I'll show in a later slide, has within it what's called passive tension. Muscles can exert force either by contracting or simply by the fact that they have a certain built-in elasticity, that they don't want to be lengthened because of a protein in them called titin and some connective tissue and things like that. The resisting to being lengthened, even though you're not undergoing nervous stimulation, is called passive tension. Now, the best example of passive tension in the world, for me, is if I try and bend and touch my toes. I can't get any further than that. And the reason I can't get any further than that, aside from being extremely old, is that the muscles on the back of my thigh have a tremendous amount of passive tension. They resist being lengthened even if they're not being stimulated. You can stretch them. If I were to do this exercise every day for a month, I would stretch those out. I would take that rubber band essentially and make it longer and less resistant, and then I could stretch them out. Well, anyway, the flexor digitorum profundus, a muscle which sends a tendon on the ventral aspect of the fingers, has a lot of tension, passive tension, and it holds your fingers curled at rest. And you have to overcome that if you're going to extend them. Now, here are the names of the bones of a finger: metacarpal, proximal phalanx, middle phalanx, distal phalanx. The plural of phalanx is phalanges. There is no such thing as a phalange. Anybody who says phalange spends a long period of time in hell. So, we will not use that word. Here are the joints between these four bones of every finger. The metacarpal phalangeal joint, the names are just so obvious you don't have to be a genius. Between the metacarpal and the proximal phalanx is the metacarpal phalangeal joint. Between the proximal phalanx and the middle phalanx is the proximal interphalangeal joint. Between the middle phalanx and the distal phalanx is the distal interphalangeal joint. And now I want to stop and ask you to look at your metacarpal phalangeal joints. That's the first knuckle. I want you to see how far you can extend your fingers. Look, woman there. Push your fingers back as hard as you can. Look at that. She gets almost 90 degrees of extension. You get almost 90 degrees of extension. You do too. How many people... Oh, excellent. That's the real question. You get even more than that? So the real question I want is, I can't do it at all. I get zero extension. How many people have more that can get some extension out of that joint? How many people can? Should be the majority of the class. It might or might not be. Some of you haven't even tried. All right. Most people can what's called hyperextend that metacarpal phalangeal joint. As we've seen, many people can do it 90 degrees. Awful lot of people can do it 45 degrees. I personally cannot do it at all. The reason, oh, by the way, this is, well, I'll explain to you why that is in a moment. These are the real names of the joints: metacarpal phalangeal, proximal interphalangeal, distal interphalangeal. But everybody abbreviates them as MCP for metacarpal phalangeal, PIP for proximal interphalangeal, DIP for distal interphalangeal. And these are the terms I will use: MCP, PIP, and DIP. Like every good synovial joint, you know, those who attended the lecture on joints, there is a capsule to these joints. But unlike all other synovial joints, or at least unique to these, the capsule is thickened on its ventral aspect in a fibrocartilaginous pad, which is called the palmar plate. And the difference between those of you who can hyperextend this metacarpal MCP joint to 45 or 90 degrees, and me, is I have a very tight ventral aspect to my capsule. The ventral part of my capsule is very tight and will not allow me to hyperextend my MCP joint, whereas most people have a fairly loose ventral capsule and can extend. The reason it's thickened here in all of these joints is believed so that when you flex and extend, it doesn't get caught. The capsule doesn't get pulled in between the bones and get stuck there. So the ventral part is made thicker to prevent the capsule from getting squished between the bony surfaces. That's the belief. Now here are the two extrinsic flexor tendons. Flexor digitorum profundus in red, flexor digitorum superficialis in blue. The flexor digitorum profundus inserts right on the base of the distal phalanx. The flexor digitorum superficialis splits around it and inserts into the shaft of the middle phalanx. You'll see that in dissection today. It's pretty unusual and pretty clever the way that this tendon splits to allow the profundus to get further distally than the actual flexor digitorum superficialis goes. I'm not going to be talking anymore about the superficialis. Flexor digitorum superficialis is used essentially in two circumstances. When you need to, it is not used. If I just go like this and flex my fingers, I don't need flexor digitorum superficialis. That's done with flexor digitorum profundus. I use flexor digitorum superficialis if I want to grab something very tightly, then profundus is not sufficient to provide all the flexor force I need, so I help it with superficialis. I also use superficialis if I want to move the digits independently. Now, flexor digitorum superficialis inserts on the middle phalanx and therefore flexes the MCP joint and the PIP joint. Flexor digitorum profundus inserts on the distal phalanx and flexes all three joints. If I want to contract flexor digitorum superficialis all by itself, all I have to do is flex the PIP joint and not the DIP, and that motion is done by flexor digitorum superficialis. If I were to use profundus, then the DIP joint would flex as well. So that I can do that with every finger. You can try it. I can flex the PIP joint without flexing the DIP joint of each of the four fingers all by themselves. That kind of independence of action cannot happen if you go to flex the DIP joint. If I flex the DIP joint of my middle finger, the ring is forced into flexion because you don't have the independent control of the different parts of the profundus as you do of the superficialis. So people, when they're taught to play the piano, are taught to play it with their superficialis. So they can bang each finger independently and not have any effect on the neighboring fingers. If you use your flexor digitorum profundus, as you go to flex one finger down, the others will follow along. Some of the others will follow along. So, superficialis. You need it for extra strength. You need it for complete independent control, such as in piano playing. After that, you don't need it. So I'm not going to talk about it anymore. Profundus is the one I'm going to talk about, and it's the one that has the passive tension that keeps your finger at rest in flexion. Here's a dorsal view. You haven't dissected this. You won't do it till Friday, so I'll just have to go through this new information for you. We see the tendon of the extensor digitorum communis, maybe joined by that of extensor indicus for the index finger, or joined by that of extensor digiti minimi for the little finger. They form a single tendon eventually, cross over the back of the metacarpal here, and at the level of the MCP joint, these connective tissue bands sweep laterally and medially, actually, sweep out to the side from the extensor tendon and sweep around the sides of the MCP joint and eventually will attach to the palmar plate. These are referred to as sagittal bands or transverse laminae. They are thought to hold that tendon in position so it doesn't slide too much off to one side of the joint, which it would do if it were nothing restraining it. This combination of the tendon and the two sagittal bands, which attach to the palmar plate and hold that tendon in position, is referred to as the extensor hood of the MCP joint. Beyond that, the tendon continues. Over the back of the proximal phalanx, it trifurcates, that is, divides into three parts. And then the three parts each get a name. The The two peripheral parts are called lateral bands. The thing in the middle is called the central slip or the middle band. The central slip, middle band, inserts onto the base of the middle phalanx. The two lateral bands sweep around the sides of the PIP joint here, join over the dorsal aspect of the middle phalanx to form something called the terminal tendon, and that terminal tendon crosses and inserts into the base of the distal phalanx, a rather complicated way for a tendon to behave. That whole splitting of the extensor tendon into three bands and the rejoining of the two lateral bands to form something called the terminal tendon, that's referred to as the extensor expansion. This is what it looks like in a nicer drawing. All right? Here's the sagittal bands, or the transverse laminae. Here's the trifurcation. Here's the central slip. Here are the two lateral bands forming the terminal tendon, inserting into the distal phalanx. That's the way to look when you dissect it, more or less, if you do. All right. This is just a lateral view showing everything I said. Don't need to go over it. If we call point C the attachment site of the terminal tendon to the distal phalanx, point B the attachment site of the central slip to the middle phalanx, and point A the point of trifurcation, here are some things that are true. In order to extend the DIP joint right here, using the extensor digitorum communis, point C has to be pulled proximally. It has to move. You know, if this were it has to go sort of up and backwards. That's how you would do it. You would pull on this tendon, and that would have to move point C proximally. But the lateral band cannot pull point C proximally unless A moves. That should be obvious from this. The only way this is going to get pulled that way is if A shifts proximally as well. But A cannot move proximally unless point B moves, because it's attached to point B. Hence, if you stop point B from moving, you cannot actively extend the distal interphalangeal joint. Part of trick 1. This, you show your family when you go home on Thanksgiving so they know your medical education was not wasted. You force the PIP joint into flexion. That means you stop point B from moving, and you try and touch your fingernails together, and you can't do it. And yeah, you can do it if you go like that, but if you don't cheat, if you hold these in flexion, you cannot touch your fingernails together. All right? And the reason you can't is because A cannot move unless B moves, and C cannot move unless A moves. And you are holding B in position and not letting it move. There's another structure associated with this extensor expansion. This is called the oblique retinacular ligament. And the oblique retinacular ligament runs from the lateral band on either side and runs across the side of the PIP joint and attaches to the shaft of the proximal phalanx. Now, the purpose of the oblique retinacular ligament is that when you flex, either passively or actively, when you flex the distal phalanx, it pulls on the terminal tendon, that pulls on the lateral band. That pull is transmitted to the oblique retinacular ligament, and that forces the PIP joint into flexion. That's what this says. Pull is transferred to the lateral band into the ORL, and that will force your PIP joint into flexion. So, parlor trick number 2. I know there are going to be people who aren't going to agree with this. If you force your distal phalanx into flexion, the proximal interphalangeal joint also flexes. And that is to promote coordination and flexion. If you flex the DIP joint, it forces the PIP joint into flexion. Now there's going to be someone in this room whose finger looks like that. Right? That's right. And the people whose finger look like that when they do it are people who can get a good amount of hyperextension out of the PIP joint. If you can hyperextend your PIP joint, you can take this oblique retinacular ligament and shift it dorsal to the axis. And if you shift that oblique retinacular ligament dorsal to the axis of this joint, then when you pull on the terminal tendon, it's going to force this joint into extension, not flexion. So it has to do with how much hyperextension you can get out of your PIP joint. If you can get some, you can get this kind of behavior, but if you're normal like I am, you cannot get this kind of behavior. All right. Now, here's the trick. Let us try to extend a finger by contracting the extensor digitorum communis. That would seem to be a very simple thing to do, wouldn't it? You just contract that extensor digitorum communis, or either of those other two accessory extensor muscles, pull on the extensor assembly, and then just straighten out your finger. Okay, let's try and do it. In this position, when you do that, when you hold your finger completely straight, you have stretched out the flexor digitorum profundus muscle so much that it exerts a half a pound of passive force. Just like a rubber band, it is exerting a half a pound of passive force just by virtue of being stretched. So, you now want to say, let's calculate how much active force that we need in the extensor digitorum communis that will hold this finger straight against that half a pound of passive force in the flexor digitorum profundus tendon. The extensor force, FEDC, the force in the extensor digitorum communis, is divided. Half goes into the central slip and the other half in the terminal tendon. So the equations I'm going to write will deal with each of these three joints. Here's the axis of rotation of the MCP joint, the axis of rotation of the PIP, and the axis of rotation of the DIP joint. And the terminal tendon has a moment arm of A. More physics, right? Terminal tendon has a moment arm of A. The flexor digitorum profundus has a moment arm of B, which is twice the value of A. At the PIP joint, the central slip has a moment arm of C. The flexor digitorum profundus has a moment arm twice as great. At the MCP joint, the moment arm of the extensor digitorum communis tendon is the same as the moment arm of the flexor digitorum profundus tendon. We've got all the moment arms, we've got the forces now, we can do the calculation. Rather than go through this, you can do this on your own if you care. All right? You can do it on your own if you care. These are the equations for equilibrium at the DIP joint. And it comes out that if you have 2 pounds of force in the extensor tendon, 1 pound of which gets transmitted to the terminal tendon, that will balance at the DIP joint. That makes sense. The moment arm here is twice as long. It's a half a pound. So you need 1 pound in the terminal tendon to balance the half pound passive force. Same equation set for the middle joint. You need a force in the extensor digitorum communis of 2 pounds, 1 pound of which gets transmitted to the central slip, and that balances the half a pound of passive tension. At this joint, we've got now 2 pounds of force in our extensor digitorum communis. We've got a half a pound of force in the flexor digitorum profundus, passive force, green is active force. What will happen? I've got 2 pounds of force here, a half a pound of force there. Yes, this is what will happen. You are not in balance at the metacarpophalangeal joint. We calculated what force you need to balance at the 2 interphalangeal joints. We calculated 2 pounds. When you put 2 pounds of force into the extensor digitorum communis, you throw the MCP joint out of balance, and it goes into hyperextension. Then, in fact, by hyperextending the MCP joint, you will end up stretching the flexor digitorum profundus even more, so that the force within it rises above a half a pound. And then that will throw the interphalangeal joints out of whack, and you get this position. And this is the position that most people's fingers, all of those you who can get extension, hyperextension out of the MCP joint, this is the position that your finger will go into if you try to extend it using extensor digitorum communis, or the other two. That position of a finger, which is hyperextended at the metacarpophalangeal joint, and flexed at the two interphalangeal joints, that is said to be the claw position of the finger. So trying to extend your finger just using extensor digitorum communis does not cause it to extend, it causes it to claw. What if I continue to contract extensor digitorum communis? Can I then get it to look sort of like that? And for most people, this is not true because the sagittal band of the hood now is obliquely positioned, and so force in the extensor digitorum communis is shunted down the sagittal band and cannot be directed into the extensor expansion. And so you cannot continue to contract your extensor digitorum communis and hope to extend these interphalangeal joints. The bottom line here, long explanation, the claw position is the only extended position you can put your finger in if you only have extensor digitorum communis. You could get around this problem in several ways. Now, we know you do get around it, don't we? Because people can do that. So we know you have to be able to get around it. You just don't walk around with your fingers in a claw position all day long. How could you get around it? Well, you could add some new thing that creates an additional 1.5 pound flexor force at the MCP joint. And if this is added to the 1/2 pound already in the flexor digitorum profundus, the total will be 2 pounds, and that will stop the MCP joint from extending. You can think about these at home if you want to, if you care. But this is a lecture where the summary is, again, 15 seconds. This is just how you get to the summary. I, in fact, can do this because I have such tight ventral capsules of my MCP joint that as I go to extend, they cannot hyperextend. That capsular force gets to be so strong that it, added to the profundus passive force, balances at the MCP joint, so I can extend my fingers using only my digital extensors. It's just the half or more of you who got hyperextension out of that joint who cannot do that, who go into the claw position. Or you could add some new thing that creates an additional 3/4 pound extensor force at each of the IP joints. This means that you would need only 1/4 pound in the extensor tendon at each IP joint, and that 1/4 pound could be produced by an active force of 1/2 pound in the EDC, and that would put the MCP joint into balance. Again, you can think about this at home if you really care about how this happens. Or you can employ some clever combination of adding flexor force at the MCP joint and extensor force at the IP joints, and that is what is done, the clever combination of doing these things. One way to do it is to use a muscle like an interosseous muscle. The interosseous muscle adds flexor force, not a lot because it's very close to the axis of rotation, and then it sends its tendon, and that tendon splits and goes partly into the central slip and partly into a lateral band. And therefore, when an interosseous contracts, it flexes the MCP joint by virtue of its straight tendon here, and then after it splits and joins the extensor expansion, it can extend the interphalangeal joints. So here's a muscle that can do the things you want done. Add flexor force to the MCP joint, add extensor force to the IP joints. You do all the calculations, look at it on your own, you can come up with, and when you do that calculation, it turns out you can get a balance at all 3 joints. A balance at all 3 joints with 1/2 pound of passive force in the flexor profundus tendon, an active force in the extensor digitorum communis of 3/4 pounds, and an active force in the interosseous muscle of 1.25 pound. So you can do it by using your interosseous muscles. And in fact, the total amount of active force here is what? 2 pounds, which is the same amount that you thought you had before. Now, here is what's really clever. Here's how you know Mother Nature's so much smarter than all of us put together. You've got this other muscle called the lumbrical. Let's forget about the interosseous muscles. That's why it's shaded here. You've got a muscle called the lumbrical which arises from the tendon of the flexor digitorum profundus. It sends a tendon ventral to the axis, and therefore it can flex the MCP joint. And it sends a tendon, its tendon joins that of the interosseous and splits and goes partly to the central slip and partly to the lateral band of the extensor expansion. So the lumbrical also can do both things, just like the interosseous. By the way, Once you have that extensor expansion joined by tendons of the interosseous muscle and lumbricals, it changes its name to the dorsal aponeurosis. This is a much better diagram of what it looks like. Here's an interosseous muscle, here's the interosseous tendon, and it sort of splits and goes to these two portions of the extensor expansion, and here's the lumbrical, and here's its tendon going to the two parts of the extensor expansion. And that all together is called the dorsal aponeurosis of a finger. All those things. Here's the leverage for the lumbrical. It's about the same as that for the flexor digitorum profundus. Not going to do all this calculation here for you because I want to say one important thing. When the lumbrical contracts, it pulls on its origin, which is on the tendon of flexor digitorum profundus. And when it pulls on its origin, it slackens the part of flexor digitorum profundus distal to it. It's like if you had a rubber band here and you grabbed this end of the rubber band and pulled it that way, that part of the rubber band between this point of attachment and that point of attachment would get slack. And in fact, for every 1 pound of force you put in your 1/10 of a pound that you put in your lumbrical, you remove 1/10 of a pound from flexor digitorum profundus. So you really are taking flexor digitorum profundus passive force and shunting it onto the backs of the interphalangeal joints. You want to solve all those equations? You can. Take my word for it. If you solve all those equations, because every 1/10 of a pound you put into the lumbrical subtracts 1/10 of a pound from flexor digitorum profundus and makes it easier to balance at these interphalangeal joints, you can balance this finger with this combination of forces. You now are down to 2/10 of a pound in the flexor digitorum profundus tendon, because the lumbrical, as I said, lowers the passive force by pulling on it. And the active force is 8/10 of a pound, much less than the 2-pound active force you needed with the interosseous. So what does that tell you? Oh, this is just to remind you of what the calculations were for interosseous muscles, how much better the lumbrical is at doing this than the interosseous muscles are. If you didn't follow the argument here, because I went through it so quickly, and you want to follow the argument, go through the slides yourself more slowly. If you don't want to follow the argument, if you just want to know the bottom line of the argument, the bottom line is most people cannot extend their fingers with the extrinsic extensors. Most people require, that is people who can get any hyperextension on the MCP joint, most people require an intrinsic muscle also. That intrinsic muscle could be an interosseous muscle, that will do the job. Or it could be a lumbrical, that will do the job. But if you use a lumbrical, you are using it with much less active force. So it is much more energetically efficient. So what do people do? They use lumbricals. They don't use their interosseous muscles to do this. This is done with an extrinsic extensor and lumbricals for each digit. And only if your lumbricals are paralyzed do you need to bring in the interosseous muscle to do this. But if either one or the other is intact, you can straighten out your finger. If none of them are intact, if you have no interosseous muscles, if they're paralyzed, and you have no lumbricals, they are paralyzed, you are said to have an intrinsic minus hand. The intrinsics are paralyzed. And if you have an intrinsic minus hand, you cannot straighten out your fingers, most of you. I could, but you couldn't. And the only reason I can is because I have such a tight capsule to my joint. The ulnar nerve, you know, innervates all of the muscles of the hand with the exception of the thenar eminence muscles, which move your thumb in opposition, and two muscles, which I didn't mention, whatever it was 2 or 3 days ago when I gave this lecture, the two radial lumbricals, the lumbrical for the index finger and the lumbrical for the middle finger. Those two lumbricals are innervated by the median nerve, as are the thenar eminence muscles innervated by the median nerve. The ulnar does all of the others. So if you have an ulnar nerve injury at your wrist, in particular, this will be more noticeable. If you have an ulnar nerve injury at your wrist and you paralyze all the ulnar innervated muscles of your hand, you have paralyzed all the interosseous muscles and you've paralyzed the ulnar two lumbricals. So what does that tell you? You cannot extend, most people, cannot extend those ulnar 2 digits. This is the position when you ask a person who's had an ulnar nerve injury at the wrist to extend their fingers. This is what happens. They try to use the extrinsic extensor. They have no intrinsic muscles for the little and ring finger, and these fingers go into what's called a claw, and this is called the ulnar claw position. So a sign for most people of an ulnar nerve injury at the wrist is an ulnar claw. You can see other signs of ulnar nerve injury here too. You see how this little pad, this fleshy mass here at the base of your little finger, feel it on yourself, it's called the hypothenar eminence. You'll see it in dissection today, hypothenar. It's concave here because those are muscles innervated by the ulnar nerve. So not only do you get an ulnar claw, but you get a loss of mass of the hypothenar eminence as the muscles atrophy. That's a sign of a hand with an ulnar nerve injury. Here is a person with an ulnar claw, and the examiner is stopping the MCP joints from hyperextending. This pad, putting a finger there and stopping them from hyperextending, and now this person can get pretty good extension out of the IP joints. That's what I told you. If you have something that stops that metacarpophalangeal joint from hyperextending, you can then use your extrinsic extensors to extend the IP joints, and that just shows in a patient how that is true. Here's a person with an ulnar claw. Pretty typical ulnar claw. You can see the hypothenar eminence, the fleshy mass at the base of the little finger, is also atrophied. Here is a different patient, actually, with much less of a claw. And you know, it is possible to have an ulnar nerve injury at the elbow and not have clawing be a prominent sign. And that's because if you injure your ulnar nerve at the elbow, you are not only denervating the muscles in your hand innervated by the ulnar nerve, you're denervating the muscles of the forearm innervated by your ulnar nerve. What are those? Flexor carpi ulnaris and half of flexor digitorum profundus. Good, excellent. When you denervate a muscle, it loses its elasticity. So here's a person who probably had an ulnar injury at the elbow. When you lose the elasticity of your flexor digitorum profundus, then those equations change entirely because you don't need that half pound down there anymore, and then you pretty much can extend your fingers. So you don't get a prominent claw. Anyway, this person has a different sign of ulnar nerve injury. It's called the Wartenberg sign, where the little finger falls away from the rest of the hand. Now, why does the little finger fall away from the rest of the hand? The interosseous muscles, the palmar interosseous muscles, squeeze your fingers together. If the ulnar nerve is injured, you lose your palmar interosseous muscles, so nothing can squeeze them together. Now, that doesn't necessarily mean they're going to fall apart, but the fact is that the extensor tendon for the little finger tends to abduct it a little, tends to swing it out to the side. So if you don't have a palmar interosseous muscle for your little finger, it is kept abducted, in not everybody, in about half the people, it is kept abducted. Half the people will have this Wartenberg sign. This is a big problem for people because when you put your hand in your pants pocket, that little finger catches on the edge of your pants pocket. It's quite annoying to people to have this thing. And you really have to surgically correct it or they'll get really PO'd at you. Also in this ulnar nerve injury patient, this one, you can see how the flesh on the back of your palm, back of your hand, between the thumb and the index metacarpal is all sunken in. That's because the dorsal interosseous muscles, which we saw at the back, are all atrophied. And so all the spaces on the back of your hand will appear concave as these dorsal interosseous muscles atrophy. So we've already seen now signs of ulnar nerve injury. You can have an ulnar claw. You can have a Wartenberg sign. You will always have atrophy of the hypothenar eminence and atrophy of the intermetacarpal spaces seen on the dorsal side. These are all signs of an ulnar nerve injury. The claw, less noticeable if it's a high ulnar nerve injury in the elbow, but all the others are unaffected by the level of injury. That look like an ulnar claw to you? No. The definition of a claw finger is hyperextension at the metacarpophalangeal joint, flexion at the interphalangeal joints. This has got flexion at all three joints. This is not an ulnar claw. So you can't see a patient like this and say, oh my God, we have to find out where the ulnar nerve is injured. If you've got flexion at that MCP joint, that is not an ulnar claw. This happens to be a disease called Dupuytren contracture. You will, very early in your dissection today, find something called the palmar aponeurosis, a thick fascial layer underneath the skin of the palm. That fascial layer can develop a kind of contraction. The connective tissue can shorten, and it can pull your fingers into flexion passively as the connective tissue, the collagen fibers of that palmar aponeurosis shorten. And it has to be treated. Now we have one of the world's experts in treating it here called Larry Hurst. He's an orthopedic surgeon. And he devised a method of injecting a collagenase into the palmar aponeurosis until the collagen breaks down enough. You inject it, I don't know how, I can't remember how long you have to wait, a week and he injects the collagenase into the palmar aponeurosis. The patient comes back in a week and he just snaps the collagenous bands of the aponeurosis, and that cures the Dupuytren contracture. But I didn't want you to mix it up with an ulnar claw because it's not the same thing. Here's what happens if you lose all of your intrinsic muscles. You know, in an ulnar nerve injury, you lost everything but the thenar eminence muscles and the radial two lumbricals. But if you damage both the median and ulnar nerve, or the lower trunk of the brachial plexus, which is essentially the same, gives up the same innervation pattern, then you get this thing, which is not an ulnar claw, but it's a claw of all the digits, because now you have a completely intrinsic minus hand. Before it was an ulnar intrinsic minus hand, I didn't make it clear. Now you have a completely intrinsic minus hand. You have no interosseous muscles, no lumbrical muscles. All fingers go into claw, and some ugly things happen to your thumb too, because it's denervated as well. I'm not going to do, oh yes, I will do this one. Is that a claw position of a finger? Yes. It's claw position of the little finger, claw position of the ring, claw position of the middle. How is that possible? Think of variation. It's only possible if this middle finger is intrinsic minus now. That means the middle finger can't have either an interosseous muscle intact or a lumbrical intact. But you say to yourself, but the middle finger's lumbrical is innervated by the median nerve. And in fact, it is in most people. But in some people, it's innervated by the ulnar nerve. And if you have an ulnar nerve which crosses over and innervates the lumbrical to the middle finger, then you're going to get this type of ulnar claw. You're going to add a finger to it. I'm not aware of anybody, my colleague Randy Sussman is an expert in the hand, may know if there's ever a case where the first lumbrical is innervated by the ulnar nerve. I've never heard of that. Here's a person who was asked to make an O, tight O, with their thumb and index finger. And you see on one side, the person's left side, it looks like that. And the person's right side, it looks like that. Which means that the person is having difficulty on the person's right side of flexing the interphalangeal joint of the thumb and flexing the distal interphalangeal joint of the index finger. So let me ask you, what muscle flexes the interphalangeal joint of the thumb? Flexor pulsus longus flexes the interphalangeal joint of the thumb. The person's having trouble, can't do it. What flexes the distal interphalangeal joint of the index finger? Flexor digitorum profundus. The person has no trouble flexing the proximal joint because flexor digitorum superficialis is still intact. You have to think of a nerve that could leave, a nerve injury that could leave flexor digitorum superficialis intact, but affect flexor pollicis longus and the part of flexor digitorum profundus that goes to the index finger, and I'll tell you also the ring, but you can't see that. What nerve do you know that you could injure that would affect flexor digitorum profundus going to the index finger and flexor pollicis longus, but not affect flexor digitorum superficialis? Anterior interosseous. This is the sign. This is how you test for an anterior interosseous injury. Ask a person to make a tight O, and if their interphalangeal joints can't be flexed, that's a sign of anterior osseous injury. Usually occurs from a trauma to the upper limb. And I think I'll just call it quits here. Leave.